Hey, well, I'm Jessica. I'm the operations lead for the Victoria South Island LTCI. I'd like to take a moment to welcome you to our LTCI Learning Series event this evening. It is with great respect and appreciation that I am speaking to you today from the traditional and ancestral territories of the Sauk Nation, where I feel very lucky to work and live. So just a couple of housekeeping items first. Please keep yourself muted if you're not speaking, as background noise can amplify quite quickly. There are CME credits available for this event. A member of the LTCI team will email you a certificate in the next couple of days for your records. At the end of this evening, we will have an evaluation. So please take a few moments to participate. Your feedback is important for guiding these sessions. This event will be recorded and posted on our website along with a copy of the slides from this evening. If you do have any questions throughout the evening, please feel free to unmute yourself and ask away, and we will also have a Q&A portion at the end. Feel free to introduce yourself in the chat if you have not done so already. We'd love to hear what your role is in long-term care and where you're calling from today. So finally, I'd like to introduce our presenter for this evening, Dr. Keiran graduated from the University of Sydney Medical School and then moved to Portland, Oregon, where he completed his neurology residency and movement disorders fellowship at Oregon Health and Science University. He moved to Victoria in 2018 to open the Parkinsons and Movement Disorders Clinic at Royal Jubilee Hospital. He enjoys gardening and playing guitar. So without further ado, over to you and welcome to Dr. Tuck.
Thank you very much. Hi everyone. I assume you can hear me. So yeah, I'm Keiran. I am a neurologist. I specialize in movement disorders, and kind of the bulk of what movement disorders is Parkinson's disease. So a lot of my patients or either live in long-term care or eventually move to long-term care. So I think it's a very good relationship that we should have. So yeah, I'm just going to pull up my slide and just see if I can share it with you. I guess what I'd say is I'm happy to make this interactive. If you guys are interested in that, please either just yell out or put your hand up on Zoom. There's a function where you can just raise a hand, the little yellow hand up in the corner. So please do that if you have a question. And I'm happy to, stop in the middle of things and chat. So without further ado, I've got a lot of slides. Probably got about 50 slides, but I'm aiming to really only talk for about 40 minutes or so. So at the end of the talk, it gets a bit kind of bogged down in some details of studies and things like that. So I might kind of just breeze through that a bit. And I think leaving you guys time for questions, and hopefully we can have a little bit of a discussion. So just as far as disclosures, I really don't have any. I'm an honorary board member of the Parkinson Wellness Project here in Victoria, but I don't get paid anything, and I rarely do anything for them. They just like having me on their website. Otherwise, I don't get any funding or anything from any drug companies or device companies or anything. So a little bit of the outline, we're going to talk about the Parkinson's disease hydra, so the many heads of Parkinson's disease, kind of specifically talk a bit about cognitive changes and dementia, which is probably a lot of the patients you guys see have these. Talk about what kind of kills people, the mortality of people with Parkinson's, and then a bit about long-term care and Parkinson's, which is, what you guys do. So just a very brief kind of intro. Parkinson's disease was first described in 1817 by this guy, James Parkinson in London. And he wrote this essay called An Essay on the Shaking Palsy. And that was what he called Parkinson's. And much later we said, well, he discovered it, so we should call it, name it after him. Instead of calling it shaking palsy, we now call it Parkinson's disease. So let's talk about, how we diagnose Parkinson's. What is Parkinson's? And I've just got a picture up here of two people, Michael J. Fox and Muhammad Ali. Michael J. Fox has classic idiopathic Parkinson's disease. And Muhammad Ali probably doesn't have real Parkinson's. He probably has what we call vascular Parkinsonism, or what used to be called dementia pugilistica. Essentially, because he's been hit in the head so many times, he's got damage to his brain that kind of makes him look a bit like he has Parkinson's. So what do people with Parkinson's look like? So as James Parkinson described, right? They shake, so shaking palsy, and that's the tremor. That's classically what people think about when they think of Parkinson's, is a tremor. And this is mainly a tremor at rest. So when the patient's arms are doing nothing, they shake. But when they hold a cup or do something else, the tremor often goes away. Now, that said, the tremor can get worse and it can spread, and it can be in both action, rest, and with posture. So it's especially in the stages you guys are going to see them kind of in the end stages. It's just tremor, and it can be kind of anywhere doing anything. And then as far as palsy, what James Parkinson described as palsy, we now call bradykinesia, which is slowness of movements. So this kind of classic kind of stiff, slow movements of patients. They look, their face is very, they don't have a lot of expression in their face because they're not moving their face as fast and as normally as we would expect. And then James Parkinson described what he called difficulty with gait and falls. We call this postural instability now. This is a big part of Parkinson's, is this kind of falling over and trouble with walking. And then the fourth sign of Parkinson's is what we call rigidity. James Parkinson didn't describe this, but this was described much later. And rigidity is something that you can't see. Rigidity is something you feel. So when you move their arms or their legs around, there's this kind of stiffness, like they're resisting you, but it's not a voluntary resistance. So this is how we diagnose Parkinson's. There's no blood test, there's no brain scan. It's really a clinical diagnosis. It's do you have these features? Then we say you have Parkinson's, because the only way to diagnose Parkinson's 100% is by autopsy, to look at your brain under a microscope and see if you have the pathological signs of Parkinson's. So when we talk about these cardinal signs, these are all movement, what we call motor symptoms or motor signs. But there's a lot of other things that go along with Parkinson's, right? That's why I call it a hydra, right? There's just so many heads to it. This is Hercules fighting the hydra in Greek mythology. But people have trouble with drooling, they have trouble smelling, they have constipation, they have bladder dysfunction, pain, anxiety, depression, sexual dysfunction, sleep problems, hallucinations. So there's a huge list of things that can go wrong in Parkinson's that don't always go wrong. So people will have a hodgepodge of these, or some people have none of these, or some people have all of these. So just good to understand that people with Parkinson's can get a lot of other issues. And while we treat these issues, these motor issues, with special medications, the rest of these issues we treat just like any other patient who has these issues. There's nothing special about these kinds of symptoms in people with Parkinson's. You treat them the same. But then, there's other things, as you guys know, right? People with Parkinson's, or people in long-term care, people who are disabled. There's a lot of issues around caregiver strain, spiritual distress, trouble moving around and getting around, relationships. Problems with planning for the future. So we really talk about Parkinson's, even though it's classified as a movement disorder, we really talk about it as it's a whole brain and a whole body condition, because it really can affect everything, and not just your brain and your body, but also your family and your interactions with society. So care is very holistic. And, sometimes this leads to patients feeling a bit like this. They feel quite overwhelmed. But that's why we're here. We're here to help them lessen the burden. So, and I like this quote that, it's not the load that you carry, it's the way that you carry it. And I think one of the things that I find very important or helpful when I'm dealing with my patients is to try to teach people coping skills and resilience, right? And ways to help carry the load that they're burdened with. So I can't do all of that. Your family doctor can't do all of that. Nursing can't do all of that. OT can't do all of that. No one can manage all of these issues themselves. So it really requires a team approach involving all of us, involving family, involving social supports, involving the community, right? So we all need to be involved in managing these patients. And this is just kind of a, just a little bit of a framework of who might be involved in caring for these patients. And you can see the ideal situation is that you have tons of people involved, right? This doesn't always happen this way, but this is really the ideal, right? As the patients here, they get close support from neurology, their family doctor is involved as well. They get rehab medicine, social work, family closely involved. And then if they have issues with their bowels or with their bladder or psychology, they have all these other people supporting them from the outside as well. So one thing that you guys probably see a lot and is a big driver, as we'll learn later, of why people end up in long-term care facilities is cognitive impairment. So let's just kind of define a few terms first as far as cognitive impairment. So first thing to talk about is pseudo-dementia. So this is subjective cognitive impairment. So people will come into my clinic and they'll say, I have trouble, organizing myself. I forget words all the time. I have trouble following things. And then you ask them, well, how do you sleep? And they say, oh, my sleep's terrible. And if they have like obstructive sleep apnea that's not treated, then yeah, of course their cognitive function is not going to be normal. But that doesn't mean they have dementia. It means they're not getting good enough sleep. Or if they're severely depressed, depression or anxiety can cause cognitive issues. So this is what we call pseudo-dementia, is they're not demented. They have something else that makes them look like they have dementia. The next step is mild cognitive impairment. So this is what we call subjective cognitive impairment. So people who have similar complaints, right? That their memory is not as good as it used to be. And they may score lower than normal on a formal cognitive test like the MoCA or the mini mental or something. There's no obvious cause like depression or sleep trouble, but there's no functional impairment. So they're still able to take care of themselves. They can still pay their bills. They can still do their hobbies. They can still interact in a normal way with society. So we would call that mild cognitive impairment. And then there's dementia. And dementia, the definition is really impaired daily function. Now these definitions have changed a bit recently. I think we're now calling dementia major cognitive disorder or something like that. And mild cognitive impairment, we're calling mild cognitive disorder. But that's just new nomenclature. Essentially, I feel like people decide they have to change the names of things every 10 years. So you may see those kinds of those terms as well. And there's various reasons people can get dementia, right? The most common is Alzheimer's disease, but also vascular disease. So lots of little strokes, or people with uncontrolled hypertension or diabetes will get damage to the brain, damage to the blood vessels, which then damages the brain and can eventually cause dementia. The kind of dementia involved with Parkinson's is what we call Lewy body dementia. So Lewy bodies, as we'll see in a couple slides, is these little changes we see in the brain, microscopic changes that are associated with Parkinson's disease. And if those changes get into the cortex, into the outer part of the brain, and cause damage there, then that causes dementia. And we call that Lewy body dementia. But also, most people have a mixture of some of these, right? You'll have vascular and Alzheimer's pathology, or you have some others, right? And there are some other very rare types of dementia that we don't need to worry about for today's talk. So, diagnosis of the specific type of dementia is essentially impossible without a brain tissue sample. And this is just a picture showing what Alzheimer's looks like with these plaques and fibrils. This is a Lewy body over here. It's this kind of circular, kind of egg-shaped thing, or egg yolk type deal that we see in the nerves of people with Parkinson's. But the reality is, it doesn't matter, right? We treat all of these kinds of dementia pretty similarly. So it's really just more important to recognize that there are cognitive problems, and we don't really worry too much about the exact diagnosis. So incidence, so how often do people develop dementia? So in one study here, within 3 years of diagnosis, about a quarter converted to mild cognitive impairment. But only 20% of those 25 over the next 7 years, I believe it was, converted to dementia, while a lot of them converted back to normal cognitive function, which to me indicates there's a lot of pseudodementia. So in patients with Parkinson's, there's a lot of depression, there's a lot of sleep problems, there's a lot of other medical issues that we need to be aware of that can affect people's thinking and memory. So prevalence, like how people with dementia, people with Parkinson's, the reality is if you live long enough, you're going to get dementia. And in this study of people with Parkinson's disease, after 20 years of disease, about 80% of them had dementia. Now, the reality is these are all elderly people. So the reality is if you live long enough, everyone gets dementia. Doesn't matter if you have Parkinson's or not. So yes, there's higher rates of dementia in people with Parkinson's, but there's also higher rates of dementia just in people as they get older in general. And I think this is important, right? So of the people in this study, a small percentage of them had autopsies, and only 8 of them had only Parkinson's as the cause of their dementia. So that's less than half, and the others had mixed pathology. So it's not always just Parkinson's that causes your dementia. In about half of people, it's a mixture, a combination of things. So what are the risk factors for getting dementia? So there's these atypical Parkinsonisms. So when we talk about Parkinson's disease is a very specific disease with these Lewy bodies here that cause damage to a very specific part of the brain called the substantia nigra. There are some other conditions that we call atypical Parkinsonisms or Parkinson's plus syndromes, where there's different pathology, but the patients kind of look from the outside, they look like they have Parkinson's disease. So we kind of lump them all together because it's often hard to tell the difference. But on autopsy, you can very clearly tell the difference. And these conditions are more likely to develop dementia than Parkinson's disease itself. People who develop hallucinations are more likely to develop dementia. People who have more severe, essentially Parkinson's disease, greater motor impairment, the more likely you are to develop dementia. And as we've talked about, the longer you have the disease, the more likely you are to get it. And interestingly, males are more likely to get it than females. Older age probably goes along with this longer duration of illness. So how do you prevent dementia? Really, there's no medications, or it's really just keeping your mind and your body strong, right? Keeping you socially and mentally engaged, and then managing other medical issues, keeping your diabetes under control, keeping your blood pressure under control, right? How do we treat dementia? There's no treatment for dementia. There are medications that can help a little bit with helping boost your cognition, help you think a little more clearly. These are certainly not miracle drugs, but they can help a little bit. So there's these cholinesterase inhibitors that you probably see a lot. We use a lot in BC here. We use a lot of donepezil, but rivastigmine is another one that's very similar. There's a drug called memantine, which is an NMDA receptor antagonist, again, that can help boost memory a little bit. And then if people are hallucinating or having behavioral issues, the main go-to is this medication quetiapine. So, oftentimes with people with behavioral issues who are demented, you'll see, geriatricians and neurologists, we use medications such as olanzapine or risperidone, but those are dopamine blocking agents. So they block dopamine in the brain, and that actually makes people's Parkinson's motor symptoms worse. So you really don't want to give people with Parkinson's disease those kinds of medications because it makes them much worse. So we use quetiapine because has a much lower activity at blocking dopamine. Clozapine is very similar to quetiapine. And then there's a drug in the US that's been approved called pimavanserin, but we don't have it here in Canada. Lifestyle is very important. And, we need to keep people with Parkinson's and dementia essentially safe and enjoying life. And I put the little Parkinson's Society of British Columbia logo down here just to remind me to make you guys aware that there are groups out there that can help these people. This is a nonprofit group that has a lot of supports and resources available for people with Parkinson's and with dementia. And then there's a local group called the Parkinson Wellness Project, which is helpful as well. So let's just talk a bit about what, to be blunt, what kills people with Parkinson's. But first, I'm just going to talk about talking to people about mortality. I think this is a big taboo amongst a lot of healthcare professionals, and certainly used to be much more taboo, right? There used to be, you'd never talk to people about death, right? That was kind of accepting failure and admitting that you were helpless or something like that. But the research has shown that people really want to talk about these things. So this is actually a research study that I did back in my fellowship in Portland. Essentially, it's just a survey of people with Parkinson's about how they wanted to talk about the end of life. And if we look, this is a question was, when should your doctor discuss, and then treatment goals and options, right? And at the time, next few visits, so or never, right? So this is right at the beginning, or wait until I ask about it, or never talk about it, right? So treatment goals, this is pretty clear. When do you want to talk about starting medications? Everyone thinks, or most people think, yeah, we should start that right at the beginning, right? Talk about side effects of medications right at the beginning. But if you look down at like life expectancy, there's a good 25% who want to talk about life expectancy right up front, right? And then another 14% who want to talk about it in the next few visits, right? So that's a good, we're up to like 40% of people who want to talk about the end of, how long they're going to live right when they get diagnosed with Parkinson's. That's a big number of people. And, similar number, about 30% want to talk about end of life care, how to plan for end of life care, right? And talk about communication, right? So I think it's really important to realize there's a big number of people who want to have these conversations. And so hopefully we are having these conversations early on. But I guess what I would say is, you in the long-term care facility world, don't assume that the patient's doctors have talked about these things, right? So it's never too late. And I guess what I gleaned from this research is that really you just need to keep bringing it up, right? You just need to ask. And if they don't want to talk about it, they'll tell you they don't want to talk about it. But if they do, then you'll have that conversation, and the patient will be happy and will be appreciative of that. And then there's a question of, the question was, who should raise these issues about end of life, right? About life expectancy. And about 65% feel like the patient should raise the question. Half thought their neurologist. Quarter thought their family doctor should do it. Advanced care planning documents, 75% thought that it's appropriate for the patient to bring it up. But these are big numbers of end of life care options. But 40% feel like the family doctor should bring it up, or it's appropriate for the family doctor to bring it up. So I think it's really important. Again, there's big numbers of people who want to talk about this, and they think it's appropriate for us as PCPs or neurologists, as family doctors or neurologists, to be bringing up these issues. So this is another research study that I did back in Portland was essentially we looked at the POLST. So the POLST in Oregon is essentially what you guys call here, or what we call the MOST. So this is we call this physician's orders for life-sustaining treatment instead of your MOST, right? So this is, essentially these orders of, saying where you want or what kind of medical care you want, and looking at people who have a a MOST versus people who don't have a MOST, and where they end up dying, essentially. So we looked at death records, and you can see people without a MOST are more likely to die in an inpatient setting. So this is hospital, essentially. They're less likely to die at home. And it's about similar dying in a long-term care facility. So just bring this up to just say, look, these MOSTs are really important. I guess for you guys in long-term care, you have them, you do it. I think people around here in BC are incredible about getting these done. And so I guess I just put this in here to say, look, it's really important that we get these done. And it's great that you guys do these and have these available, because I think if you asked most people, would you rather die at home or in a hospital? I think it's something like 80-90% of people say they'd rather die at home. So, I think these kinds of documents help people achieve what they want at the end of their life. So what about actual death in Parkinson's? So this is kind of a meta-analysis from 2014 looking at mortality. Essentially shows there's higher mortality in people with Parkinson's disease. The same meta-analysis of different studies essentially shows that the mean duration of disease from onset until death is about 10 years. This is really hard data to kind of piece out, I think, just because care of patients with Parkinson's has improved drastically since 1967 to now. And it's really hard to know, with data like this, what are the comorbidities? There's just so many confounders to data like this. And that, is this an age thing, right? I mean, most people with Parkinson's are older. So are you counting the person who had a heart attack? Is that death from Parkinson's? I mean, they probably would have died anyways, even if they did have Parkinson's. So this kind of data I kind of take with a grain of salt. There's another study we did in Oregon looking at median age of people at death. And it's essentially 83 years old, which is this is people with Parkinson's essentially died, had the same life expectancy as people without Parkinson's. So, my impression is that with modern, and from the research, is that with modern medical therapy, people essentially have the same kind of life expectancy with Parkinson's as without Parkinson's, as long as they engage with that medical care. And it's really your other comorbidities that feed into your morbidity, or why you're going to die. So I think this is, again, another kind of, review of death in Parkinson's. And I think this is the key points from this study is, look, although patients with Parkinson's have reduced survival, it's highly dependent on the type. So your comorbidities, essentially. And really, if you have normal cognitive function, it seems to give you a normal life expectancy. So I think that's the key. And we're going to talk a little bit more about cognitive function, but I think this is really what drives death in Parkinson's is cognitive function. And people who are cognitively normal lead normal lives, and people who are not cognitively normal do not lead normal lives. So how do we predict survival? So this is going to get a little bit dense. I've tried to kind of clean it up a little bit, but so essentially this is American data. They looked at essentially Medicare beneficiaries. So these are people 65 and older who have Medicare, which is the essentially health insurance, government health insurance for the elderly in the US, right? So they identified all of those people in this 6-year period who had Parkinson's disease. And essentially the only things that kind of predicted survival, or some of the things that predicted survival, were being female. You're less likely to die within this 6-year period. If you're Hispanic, you're less likely to die. And if you're Asian, less likely to die. And then dementia, cognitive impairment was associated with a significantly higher likelihood of death. So again, right, males are generally just less healthy than females for a variety of reasons. I don't know what to say about the Hispanic and Asian thing. I will leave that to others to discuss. But it's clear that dementia, cognitive impairment is not good for you, and is probably the big driver of death in Parkinson's. So one of the interesting things from this, we looked at this study previously, is how many of these people are still seeing a neurologist after 20 years of having Parkinson's. It's only half, which I think is a big problem, right? If you have Parkinson's, you really should be seeing a neurologist pretty regularly, especially if you've had it for 20 years. So let's talk a bit about nursing homes. So this is a Dutch study from Holland. And I think the key thing to look at is just up over here, right? And this is years from start to nursing home admission. So years, everyone that they looked at, so this is a kind of a cohort study. They followed people over numerous years, people without Parkinson's and people with Parkinson's, and they looked at how many ended up in nursing homes, right? And after about 6 years or so, about half of the Parkinson's patients are in a nursing home or in a long-term care facility, as we call them here. Whereas only about 10% of people who are not with Parkinson's end up in a long-term care facility. So that's very interesting. And then this is death, right? So controls versus people with Parkinson's for study onset. And after about 8 years, about half of the patients with Parkinson's are dead, compared to about 35% of people without Parkinson's. So certainly, just interesting trends that people with Parkinson's are more likely to go into nursing homes, and in this study, more likely to die. So what happens in nursing homes? Now the Dutch do great research on their nursing homes. So this guy, Bas Bloem, is a big name in the Parkinson's community, does a lot of research into nursing homes and elderly people with Parkinson's. So this is a very qualitative study, right? So you take it with a bit of salt, but it was just a survey of 15 nursing home residents in the Netherlands who have Parkinson's. And they just kind of identified some things that people complain about in long-term care facilities, right? And they complain of a lack of support or empathy for the patient. They complain of lack of involvement of the neurologist, right? They complain about things like overcrowding, right? It's a huge one I hear a lot, is medications not given on time. One of the real keys to Parkinson's management is patients need their medications when they need their medications. And if they're delayed by an hour, that can be really detrimental to the patient, right? So, and then this kind of, lack of PD knowledge among nurses. And this is not to, I'm not here trying to point fingers or make you guys feel bad, but I think it's important to know what patients and caregivers, what they're looking for, what they find important. And I guess I would agree with all of this. I think this is all really important stuff. And when I hear complaints from people who are in long-term care facilities, these are all the complaints I hear, is they don't know anything about Parkinson's. I don't get to see my neurologist enough, and my meds are not given at the right time. So just some food for thought, right? So, this was their conclusion. Essentially, care is suboptimal, and we need to do a better job. I guess this is another study from the Netherlands, looking at essentially what they did is they went into a nursing home and they took all the patients who had a diagnosis of Parkinson's, And, well, they just reviewed a whole bunch of patients, right? And they said, well, is this really Parkinson's? And, or they looked at people and said, do you have Parkinson's? And so, um, 19 of these patients, right? They diagnosed with something with Parkinson's, right? And 17 of them, they said, oh, you have a diagnosis of Parkinson's, but you don't really have Parkinson's. So I think this is just more further, data that just because someone comes into a nursing home or a long-term care facility with a diagnosis doesn't mean it's right. And really, this is why this ongoing, care from a neurologist is really important, right? To make sure that we've got things right, because there's a whole bunch of people here that they reclassified, and hopefully, that they're getting better care because they've got a correct diagnosis now. This is another interesting study, essentially where they looked at the motor symptoms of people, with Parkinson's disease. And I think the key here is that, if you look up here, dyskinesias. So dyskinesias are a symptom of Parkinson's. It's like the wiggles, like if you've seen Michael J. Fox on TV where he just can't sit still. This is a side effect of the levodopa. And it actually means the levodopa is working. And most people who have Parkinson's, it doesn't bother them. That's really the way they want to be. They'd rather be dyskinetic than be stiff and slow. And so for a lot of patients, we aim for that. We say that means you're doing well, you're dyskinetic, things are working well for you. And so they went into this nursing home, and about 3/4 of the patients never had dyskinesias, which to me means they're very underdosed. And then the severity of off periods. So times when the patients are off, meaning stiff and having trouble moving. And again, 3/4 of patients are having off periods, about half are having it considerable part of the time or most of the time. And then 3/4 are having it, it's only a quarter of patients who are having no off periods. So to me, I interpret this as essentially we're terribly underdosing people with Parkinson's, and that we really need to be doing a better job adjusting and managing medications in people with Parkinson's, because these are a lot of people who are suboptimally managed and are probably really uncomfortable and really unhappy. I'm going to kind of skip through that. So death in nursing homes. So again, nursing home, long-term care facility, very similar thing. So what predicts mortality of people in a nursing home? From this study, in 3 years, about 50%. Seems very high to me. But I think the keys are really just, as we've talked about, the older you are, the more likely you are to die. If you're male, we've talked about that. Functional impairment, essentially the more disabled you are, the more likely you are to die. And then cognitive impairment, again, big one. But then other things, vision problems lead to mortality, pressure ulcers lead to mortality, right? We can intervene on this one. Congestive heart failure leads to mortality, diabetes, pneumonia, et cetera, et cetera. Some of these we can't do anything about. We can't change age, we can't change gender, functional impairment. Yeah, we can help with that, adjusting medications and try, occupational therapy, physiotherapy, right? We can help with that. Maybe not get rid of it 100%, but we can help with that. Cognitive impairment, we can help, there's some medications as we talked about that can be helpful. Pressure ulcers, we certainly can help. Vision problems, I mean, I don't know how many patients come in and they don't know where their glasses are, or their hearing aids don't work. Those are the kinds of things that are really detrimental to patients in, when they're in long-term care facilities. And we can help all that. Again, this is kind of similar information, just essentially, I'm going to skip through that, kind of just reaffirms everything we've talked about. So I think just in summary, Parkinson's is a complex, life-threatening illness. that really requires care from a multidisciplinary group, right? It requires neurologists, family doctors, nurses, physiotherapists, right? It's not something that one person can manage. This is a group exercise, and we all need to be involved. And then, you're going to see a lot of people with PD in nursing homes. I guess, I put maybe inadequate. Nursing home care may be inadequate. I think it's, probably varies. There's probably good places and bad places, just like there's good doctors and bad doctors. And I think it's just important to strive for your facility to be a good facility. And I'd really, I encourage interdisciplinary care. And I think one thing that I would ask from you guys is when you're sending people to see a neurologist, they really need a summary of what's happened. If we're seeing them once a year or every 6 months, we need to know what's been going on. They need to come with someone, family member or a caregiver or a nurse or someone who knows the patient and can help us help the patient, because we're all involved, and we're not just as neurologists doing this all on our own. So that's the end of my talk. Happy to take some questions or, yeah, thank you very much. All right.
So feel free to unmute yourself and ask away.
It's Andrea Wilhelm. I'm a family physician, and what I struggle with in the population that I look after is people obviously love their Cinnamate for very good reasons, but we get to doses where it's a challenge to get functional mobility without psychosis.
Yeah. That's a great question, right? That's a fine balance. So the reality is, levodopa rarely causes psychosis. So levodopa can cause mild hallucinations, but really psychosis is from dementia. And so you need to treat the dementia. So, these people need to be on cholinesterase, they need to be on something like donepezil. They need to be on quetiapine or clozapine. I think the reality is, we need to be more aggressive about treating cognitive issues and treating hallucinations and treating, mental health, and not just dropping their levodopa. Because in my experience, dropping levodopa, helps a little bit, but doesn't help a lot, and probably makes things much worse, because the patient's motor function is worse. Then they're going to be more agitated, more aggressive, more upset. So my recommendation would be, more Jerry Psych input, right?
The other challenge we have is you add the quetiapine and it makes the postural hypotension worse, as does the Cinnamate, as does the Parkinsons. So we have a few people we're really struggling with that, where they're not able to safely mobilize because they can't stand. And we've tried fluorinephrine salt and midodrine. Do you have any other advice?
Yeah, no, that's tough. So yeah, that's really the advice is, compression stocking, these abdominal binders, fluorinephrine, midodrine. Yeah, no, that's tough.
Yeah.
Yeah. No, I don't have any. Yeah, you're doing the right thing there. I don't have any more to add to that, unfortunately.
Do you have any experience with, first of all, thank you for a terrific talk. So practical and lucid. I've looked after late failure Parkinson's for many years now. I'm an old man, and watched it from the time that Cinnamate was actually L-DOPA, and it was called R4602 in 1975. That was its investigational number, which we all had to memorize because the head of pharmacology ran in and said, Eureka. And it really was a powerful and transformative time in the mid-70s. I'm looking after a lot of people with Lewy-ishness, which is what I call it. I trained in geriatric medicine and now do nursing home medicine consulting and primary care. And my experience with rivastigmine is different from that of donepezil. And you'll have read Ian McKeith's notes from 20 years ago when he tried to point out that he thought that there were some specific aspects of rivastigmine that were unique relative to the other acetylcholinesterase inhibitors. And I wondered if you'd had any experience, because I find that the emotional incontinence, sometimes the functional incontinence in those who are less afflicted, not nursing home, but community people with Lewy-ishness. And again, what I liked about what you said is that the etiology is somewhat less important than the phenotype, although classically, my experience is that rivastigmine works best in improving attentionality, reducing hallucinosis, and that sort of semi-delirium that McKeith talked about, which is, that the ability, the distractibility that you see not dissimilar to deliria. So do you have any thoughts about that? Do you have any experience, and am I making any sense?
Yeah, I mean, I must say I'm not a cognitive specialist, so I really don't have any great insights into the differences between the different cognitive enhancing drugs. So I don't. I mean, I kind of am in the situation where I just kind of try one. If it helps,
Yeah.
great. If not, try another one. If it doesn't help, try another one. So
Yeah.
I don't have any great insights into that. Sorry.
That's good advice. I think the other thing I want to say is that, the paradigm of care that we're using in late life care is somewhat different from classical neurology or the acute care model or rehab model of care. We're doing a lot of what you might call palliation, relief of suffering, that and doing no harm first and foremost. And that is the dialectic that we struggle with in late life care as physicians is, am I going to be adding, cognitive enhancer, and at what cost, as the previous speaker noted? What about all the dysautonomia, the sweating and they're awake, they're asleep, they're up and down. There's a lot of pressure from families to try to ameliorate these terrible, terrible symptoms. And I think that your role, as you say, as a neurologist, may be very useful to us in relieving suffering. That really is where we're at, though, at the level we're talking about in nursing home Parkinson's, late failure, advanced.
Yeah, I agree. These are complicated patients. And yeah, I think, they got a lot going on. It's hard to balance, juggle the different balls for sure.
Thank you.
Hi, Dr. Tuck.
Hi.
Do you visit any of your Parkinson's patients in long-term care?
I don't, no.
I think thinking about
Yeah.
some of the patients in our care facility, it would be really difficult just to transport them.
Right, right.
I think that would really take a lot out of them, and
Yeah,
put,
I mean, it's hard,
burden
right?
on
There's,
caregiver. Yeah.
I mean, I totally understand. I think, the problem is there's only I'm the only movement disorder person in the South Island. My wait list is like 1.5 years at this point. It's I can only do so many things. Yeah, I don't know. It's hard. I think, we had a divisional, like, a provincial wide neurology meeting just last week, and we talked about they've put up a new fee code to try to encourage, I guess, just kind of electronic advice. So essentially, if you have questions about patients, they're trying to encourage family doctors and other doctors to just call us or send us referrals with just like questions like, hey, I don't think you need to see the patient, but what should I do about this? And so I think, trying to do things like that would be, it can be helpful, yeah, I agree. There needs to be more of us. And I think, another thing is we probably need to have more, nurse practitioners and, who are trained in neurology, who can, go out and do those kinds of things as well. So I get it. I totally understand the issues, and it's hard.
Yeah, and the other thing about the timing of the levodopa, knowing how important that is for our Parkinson's patients and clients, really difficult when you have one nurse administering medications to 40 residents.
Yep.
with a 2.5-hour window, right?
Yep.
Really, really difficult. So I just think that we should acknowledge the challenges.
Mhm.
If a Parkinson's patient had home care or someone that could, spend a lot more time with them, I think probably their quality of life would go up.
Yeah.
But in long-term care, it was very short-staffed when we were at baseline, and now we're not even meeting baseline, right? So
Yeah.
anyway, just so you're aware, I think that
No,
everybody wants to do all these wonderful things for their patients, but we're up
Yeah.
against like quite a challenge.
I know, I get it. It's good. I think it's good to recognize what we should be doing, but understand, the limitations. I get it. Yeah.
Dr. Tuck, just getting back to site visits, which I can't even imagine how you would manage that. But I do know you have a nurse practitioner now in the movement disorder clinic. I don't know if there's any capacity for her to do that, or if not, that do some Zoom sessions or.
Yeah, so we do Zoom. So I do have, a few, a handful, I don't know how many, half a dozen patients that I do Zoom sessions with at long-term care facilities. I think that can be really helpful. I think the most helpful thing is having a nurse or someone there, a family member there who knows the patient as well. But yeah, so Zoom sessions I think have been great, since the pandemic, we've been doing that a lot. I think that's helped a lot. And doesn't require travel. So yeah, we do have a nurse practitioner. She's she's only been working with us for, I guess, 6-7 months now, and she'd never done Parkinson's before. So she's kind of just getting her feet wet and kind of learning the ropes at this point. And there's a lot of other asks on her at this point. And I think one of our bigger priorities, unfortunately, rather than long-term care, is if we do send her out, we're going to send her to the inpatient services to try to help inpatient at Jubilee, because we really have very little neurology coverage at Jubilee. So yeah, it'd be great to have another nurse practitioner that we could send out into the community. So we'll see.
Okay,
but
thanks.
I don't see that happening anytime soon, though, unfortunately.
Yeah. Well, that's fine. I mean, it's good to know that Zoom is an option potentially.
Yeah, definitely. I think Nino Loterio, do you have a question?
Oh yeah. Hi, Dr. Kra. Thank you for your talk and sharing your knowledge about this topic. My question is, how will I know if my Parkinson's is getting more advanced?
I mean, Parkinson's is a slowly progressive disease. So over time, it does slowly get worse. The tremor will get worse, the slowness, the stiffness gets worse. People develop balance problems.
Yeah.
Is there a kind of I mean, it's a very broad question. If it looks like it's getting worse, it probably is, and it certainly does.
Like if there's like in a couple of days, weeks, you have another symptoms like that's getting more advanced.
Sorry, I didn't hear the first part of that question.
I mean, so it's getting more advanced. Like you already at the symptoms, and then a couple of days, weeks, and then there's another symptoms. Is that like it's getting more is it getting worse?
Parkinson's, like most neurologic conditions, well, I shouldn't say that, but Parkinson's slowly gets worse. You usually don't kind of fall off a cliff. Things don't change suddenly with Parkinson's, right? It's a gradual neurodegenerative disease.
Yeah.
So, I often tell my patients, they'll call me and say, hey, I'm suddenly, in the last week, this has happened and it's very different. I suddenly, I'm having trouble peeing, or my husband is suddenly incredibly confused. And I always tell them, look, if something has changed suddenly, you need to see your family doctor, or you need to go to the emergency department to check out, right? Because that usually means, something else is going on. It's not the Parkinson's, right? Might have been, comorbidly involved with the Parkinson's, but if things are changing suddenly, that's usually not Parkinson's disease.
Okay.
Does that?
Thank you, Dr.
Yeah. Oh, you're welcome. I think there are a
Full-
few questions in the chat. I might.
We
So
do have a couple.
yeah. So there's a question. Oh,
No, go ahead.
oh, I can ask it. Yeah. So someone asks, how many neurologists are seeing Parkinson's, and names, please? So in Victoria, I think all of us probably accept, or probably most of us accept referrals for Parkinson's disease. So all of the general neurologists, all of the subspecialty neurologists will see someone with Parkinson's. As far as people who are, fellowship trained movement disorder specialists, that's me. I'm the only one. Up in Nanaimo, there is Dr. Omesh Kulkarni, who's been there for almost a year now, and he's a movement disorder specialist as well. So it's great we've got his expertise. Yeah, so I think most of us see Parkinson's, but as far as specialists, it's only myself and Dr. Kulkarni here on the island. So then someone asks, you mentioned timing of medications. What is the best time to administer levodopa, and how spaced should doses ideally be? I cannot answer that question. That's totally patient specific. So that's very individualized. There's no answer to that. Let's see. Okay.
We have a question in our question and answer
Oh, yeah.
section here from Dr. Woodburn. We have a systemic issue of staff shortages in LTC, so always a push to reduce med passes. Is there a real downside to switching from short acting to sustained release?
Yes, definitely. So yeah, let's talk about the sustained release levodopa, or CR. It's levodopa carbidopa CR. And the joke around the water cooler is that CR stands for crappy release. So the research shows that the CR formulation is really erratically absorbed. And even if you get a good absorption of it, you're really only absorbing 70% of the pill. And so often what you find with people who are on the CR levodopa is that sometimes the pills work, sometimes they don't. And it's a really kind of erratic type of medication to use. So I really don't use the CR much. It's not a good substitute for the immediate release. I guess the times I will use it, there's a couple times. So I use it at bedtime to try to help get people through the night. And the theory behind why that would work better is that your gut just slows down at night. So you're more likely to absorb the drug. Whereas during the day, you're eating, you're drinking, your gut's moving quickly, and it just pushes the pill through before you have time to absorb it. But at nighttime, it seems to have a more kind of, it just works more reliably. Now, there are some patients that I'll put on a combination of immediate release and slow release during the day. So, say give them, a tablet of immediate release and a tablet of slow release QID, just with the hope that they've got a little bit of kind of underlying levodopa throughout the day, but they're still needing that boost of the immediate release regularly throughout the day. So I guess I would really recommend against, trying to shorten or reduce dosing times using CR. I think you're going to run into problems. So the ways to reduce dosing times or dosing frequencies is by using the extender medications. So drugs such as entacapone or selegiline or rasagiline. And these are medications that work on various enzymes in the brain to essentially stop the breakdown of dopamine. And it essentially keeps more dopamine in the brain for longer periods of time. So those have good evidence that they can extend how long each dose of levodopa lasts for. So that's where I would go instead of the CR. You can try the CR, but I wouldn't completely get rid of immediate release and replace it with CR. Yeah, I guess another thing we should talk about just is kind of briefly is just kind of these next step therapies, which is like the duodopa pump or the deep brain stimulation. Because people who are having really frequent levodopa dosing, we try to get them onto one of these other therapies. So the duodopa pump is essentially a J tube. So, like a tube in the stomach. They carry around a little pump that just continuously pumps a levodopa gel into their intestine. The idea being they turn it on in the morning and then they have a steady stream of levodopa throughout the day. Really doesn't require a ton of maintenance. They're very hesitant to give it to people who are in long-term care facilities just because they're just worried that it won't get taken care of properly, which I'm trying to push the people in Vancouver to be a bit more liberal about that, because I think there's probably a lot of people in long-term care who would benefit from this. And really all that needs to be is, turned on, put the cartridge in, turn it on in the morning, and then you don't need to administer meds at all throughout the day. And then at night, you take out the cartridge, give them a couple pills, put them to bed. I think that would be great. Likewise, the DBS, generally, you're only going to see people who've had, in long-term care, you're only going to see people who've had that, many years ago, because a contraindication for it is cognitive impairment. And so many people in long-term care have at least mild cognitive impairment. They're probably not going to get it while they're in long-term care.
Any hope for the transdermal?
It's still in research stages. Yeah, I think that would be great. If we can do like a, like an insulin pump type thing with levodopa. Yeah, it's still being researched. Not ready for prime time, but I am hoping in the next 5 years or so that'll become pretty common. I think that'd be great.
I had another question come in here. Can you comment about the protein redistribution diet? Is it effective?
I guess I would say I'm not familiar with the specific name of this diet. I guess what I can say is that certainly protein affects the absorption of levodopa. So protein competes for binding sites for absorption of levodopa in the gut, and then also transport from the bloodstream into the brain. So sometimes people will have, when they eat protein, meat and dairy, they'll find that their levodopa is not as effective. This usually only happens kind of late in the disease. I find people early in the disease don't have this problem, but later in the disease, yeah, this can be a big problem where people have to really adjust when they take their levodopa to, be around, and not when they eat food, or not when they eat protein. So they'll have to take it, half an hour before protein or an hour after or something like that. So certainly is a real thing, protein affecting the absorption of levodopa. I'm not familiar with this specific diet.
Thank you. I don't know if the person who submitted that question wants to expand on that at all, or if that maybe answered the question. It's a pretty fulsome answer.
Oh, you're welcome.
Wonderful. Well, that's all the questions I can see here. If anybody has anything they'd like to ask, if you'd like to raise your hand or just unmute yourself and go ahead and ask.
Oh, you're muted, Alana.
No, sorry. Jessica, if you want to go ahead, I don't have any other questions here. Oh, unless the caller who just came in has anything they'd like to ask.
No, thank you.
No problem. All right, Jessica, I'm going to turn it back over to you then.
Yeah, that's great. So if there are no other questions, then we can end up for this evening. Thank you very much, Dr. Tuck, for coming to speak to us. It was really appreciated. Great presentation.
Great talk.
Thanks for having me. I appreciate it.
Thank
Yeah,
you.
good to meet you guys.
Yes, you too. Thank you so much. Everyone have a great night.
Thank you.
Thanks all.
Good night.
Bye, guys.
Thank you. That's it.